Dr. Honore, thank you for joining us on MD Newsline. Can you please introduce yourself to our audience?
Awesome. I'm Collette, Era Honore. I'm a dermatologist who owns her own practice on Hyde Park Dermatology in Southside of Chicago.
So, we're going to be talking about psoriasis today, and I just want to dive right in and just ask you when it comes to diagnosis, when a patient presents with chronic scaly plaques, what are the specific bedside features that push you towards psoriasis versus atopic dermatitis, for instance, seborrheic dermatitis, tinea, anything else like that?
It's anatomical location and clinical presentation. So most people look and go, the textbook goes red, scaly plaques, that's psoriasis, but it doesn't present that way in everybody. It depends on your skin type, color, and melanin. So if there's symmetrical, elbows, knees, trunk, usually steer towards psoriasis. If it's on the antecubital, which is in front of the elbows, or the popliteal fossa behind the knees, along the eyelids, you think about atopic derm. Seborrheic dermatitis, you think about flaky, greasy scales in the scalp or in the central part of the face. So you're looking anatomically.
Mhm. And when it comes to presentation and different skin types, what are some of the pitfalls or places that you think that dermatologists should pay more attention to? Let's say in diagnosing this in like African American skin, for instance.
So we don't usually present with red, scaly, silvery scale. It's not that perfect. So we'll have more purplish, brownish, grayish hues to our plaques, and then they're scaling with them. It's still going to be bilateral elbows, knees, trunks, or it can most likely be in the scalp or just in the scalp alone, genital areas. And then it's the history. How did it show up? When did it show up? So history does take a toll. Usually psoriasis presents later and not earlier in life.
Mm-hmm. Do you have a way that you systematically examine distribution in special sites, such as scalp, ears, things like that, to build or break a diagnosis of psoriasis? Does it
Yeah,
matter?
I go pull up your elbows. Is it on both sides or one side? If one side, you steer towards more eczema or contact dermatitis, whereas psoriasis, you know it's going to be symmetrical. And usually, when people don't know, you should biopsy. That's the advantage of being a dermatologist, but it's pretty much easier to see.
Mhm. What are the top diagnostic traps you see in referrals, especially facial, inverse, palmoplantar, or scalp psoriasis? And what simple habits would help clinicians stop missing these?
So we treat our hair differently. Everybody does. We don't wash our hair as often because it's drier, first and foremost, and not as greasy. So you can have somebody go, it's a little itchy and scaly, wash your hair every day with that. So at that point, the person's not even going to do the treatment. They're going to be like, well, I'll just live with it. Hair is falling out, and you're thinking it's psoriasis, but not necessarily. It could be seborrheic dermatitis. Um, I've had various patients who've come in who've been treated for years thinking they had eczema, getting worse. Arthritis starts to kick in, and those are other symptoms that come with psoriasis more so than eczema. Pitting of the nails, and then they're trying to figure out, why am I putting on all these topicals and nothing's working? And then it leaves a bad scarring on us more than anything. So you walk around, even if they do go away, you have these dark blotches all over the body. So pitfall would be, let's look at it. Is it look like psoriasis? Then it is psoriasis, not because it's in a black patient versus a white patient.
Hmm. And when it comes to things like those black blotches with things like psoriasis, what are the next steps after treatment? Let's say an ideal scenario. Is it just kind of permanent, or are there kind of treatment options for things
So it
like?
depends on early detection or early diagnosis. So when people can come in and we can see them, we can be aggressive. And you can start people with topicals depending on how much surface area is affected by that person and how long before they were underdiagnosed, undiagnosed, misdiagnosed. So if you can aggressively treat them, oh no, you can clear it up quickly and get rid of some of that scarring. But to be honest, I would say about 60% of the times I've seen people come in and they weren't treated for years. And so it becomes more after we treat them and trail them up to try to do bleaching creams, chemical peels. Laser isn't the most conducive for the African American skin all the time.
Hmm. And in what scenarios do you insist on a biopsy, and what do you ask? What do you ask your dermatologist to specifically? Hold on a second. Let me restart that question. In what scenarios do you insist on a biopsy? And what should people really consider when they're thinking about biopsying a patient?
So there are more, I guess, life-threatening, not guess, life-threatening forms of psoriasis, erythrodermic psoriasis, where it's more erythema all over the body, removal of skin is shedding. Um, those are life-threatening, should be in a hospital, you're going to biopsy and make sure that you haven't missed anything. Is it like a drug eruption like Stephen Johnson versus erythrodermic psoriasis? That definitely calls for a biopsy after you've put that person in hospital, of course, to be seen. Pustular psoriasis also has, and not just the palmar pustule, the pustule all over. Also, I would call for a biopsy if it doesn't respond to treatment. And I would start off with going how much body surface is there. You can start off with topicals, oral by anti-inflammatory medications like methotrexate, cyclosporin, or oral prednisone. And then, of course, there are biologics. So you would start doing that. But if there's no response, then yeah, you should do a biopsy if you're not a dermatologist, because most dermatologists can pick up keys on psoriasis. But if you're not sure, it's the easiest tool you have in your armamentarium.
Mhm. So let's talk a little bit about assessing severity and deciding, if the psoriasis is hard to treat. Practically, how do you decide whether a patient is a topical only patient or needs phototherapy or should go straight to systemic or biologics beyond the rigid PASI or BSA cutoffs?
Yeah, that's always usually what they want, especially with insurance companies. But to be honest, you're looking at your patient. What's their quality of life? You can have people who can't pick up things with their hand. I wouldn't stop at a topical immediately. I'm like, you need to start applying for biologics. And that's something you should take in consideration. Or treating with them an oral on first consultation. People who are depressed don't want to be intimate with their partners because of the psoriasis, the flaking, or not wanting to go to school because teenagers get psoriasis, children get psoriasis as well. So you have to look at, I think you take everything into consideration when you're thinking, how do I start proceeding? I do start proceeding with topicals for everybody because you still have to get things covered for people.
Mm.
But if it's more severe, if it start to, especially infringe on quality of life, you start putting in the orals and the biologicals right there and then.
Hmm. And when it comes to applying for a biologic and getting things covered, tell me a little bit about what that journey is like and, what hurdles patients have to jump to get there.
So, and I understand the cost of these medications are in the 30,000s for the year. So most insurance companies are a little bit more cautious going, are you just going to put them on, stop them? We're giving them this medication. Well, you should have a dedicated staff that does prioritization. You usually have to do a step process. What did you give them first, doctor, before we jumped into this? And that's when they do look into BSA, the body surface surface area, to make sure that am I covering enough? Is it severe versus mild? Um, but that dedicated person and being persistent about applying for it is how you get that medication covered.
Mm. Are there alternate routes that you take? Have you crossed scenarios where a patient has not been approved for a biologic, but they needed a biologic? And then what is your approach to kind of, tackling that issue?
So tackling it, I reached out to pharmaceutical reps of the pharmaceutical companies because there's indigent services. There are saving programs where they go, they haven't covered you. Let's give your patient the drug. You've been this for 3 months, and then you try again. And now you've proved to the insurance company we've tried other things. They've gotten free samples. They've gotten better. There is success. Let's get the drug covered, and that works as well.
Yeah, interesting. And when it comes to education and deciding which treatment to go with, what is patient education like? Because, we see some commercials for medication, and I'm always curious, if you see a targeted ad for some biologic or something like that, are people really coming in and asking for a specific biologic? And do you see that often when it comes to things like psoriasis?
Absolutely. Those time slots are well placed,
Yeah.
especially during sporting events. So people come in, I saw this person, they kind of reminded me of me.
Mm-hmm.
And do you think I can get that drug?
Mm-hmm.
But it also is a double edged sword. I've also had people ask me for a drug they had no reason to get. It's like that doesn't really pertain to you. But those advertisements do work because some people don't even know that there is a treatment for what they have because they've been deterred throughout their life as well, especially in our community.
Mm-hmm.
Like, you're fine. There's nothing wrong. You won't die from it. And then everybody else is getting better. They come to see me and I'm like, oh, yeah, we can treat you. Well, I didn't know that.
Mm-hmm.
So that's disheartening to hear sometimes as well.
Mm-hmm. And when it just comes to kind of thinking about severity of disease, which sites like the scalp, face, genitals, nails, hands, feet, things like that automatically upgrade disease severity for you, even when surface area is small? Is that something that happens? And how does that change your choice of therapy?
So palmoplantaris with the palms and sole, especially because they get pustular, even though they're not infectious, they can't really function. So there's a thing in psoriasis called cognirization. You touch, you hurt the area, you'll get new lesions. So there's not one person that I know who can get through a day in their life that doesn't use their hands or walking in their shoes. So it gets debilitating, affects economic lifestyle. So yeah, even though those are small areas, they're tough areas. The scalp is hard to change too. You're trying to go to work. You're trying to, let's talk about people with high profile jobs. You're going to need something, even if it's not all over the body, the scalp needs to be treated. Genital areas are equally as important, and it does happen. And it's not areas you can say, let's throw them into a light box because you want to make sure, like with us, we don't have further discoloration of other parts of the body or, light exposure in genital areas. You worry about skin cancer later on.
Mm-hmm. And what is the world of phototherapy like these days for things like psoriasis? Because, things like red light therapy are hitting the market. So,
They
what are
are.
your thoughts on that? And do any of those cross over into the world of psoriasis, or is phototherapy for psoriasis
So
completely different?
phototherapy like UVA, UVB, especially narrow banded UVB, still is predominant. It still works really well, especially for people who don't want to do biologics.
Mm-hmm.
I think it works really well. You just got to be careful how you do it and how much exposure is given to people. I always tell people, especially if you're suffering from hair loss, cover your head if especially not involved because you don't want burning on the scalp or you don't burning anywhere else.
Mm-hmm. How do you screen efficiently for things like psoriatic arthritis and key comorbidities during standard visits? And when should a dermatologist not wait, i.e., let's say immediately escalate or refer?
So it's all about your history. So you come in and you don't ask somebody if they have associated arthritic problems or joint problems, and they would never say it to you. So that's something that needs to be part of your history and physical. And even you can see it in an exam. You should be looking, especially since the skin distribution for psoriasis is symmetrical. Psoriasis or psoriatic arthritis is not, it's asymmetrical. One large joint can be affected. The sausage fingers, because they look like they come on the knuckles and they look like little
Mm-hmm.
sausages. So those are things you should be doing on your physical exam as well, because you want to stop it before it becomes debilitating for that patient. And not every biologic addresses psoriatic arthritis as well. So people are looking for one thing. Sometimes, I've had people come back in. I didn't see it on an exam, but they'll be like, wow, my joints feel better. I'm like, wow, that worked out. So going for a biologic that also takes care of the arthritis also helps as well.
Hmm. Do you have a case in mind where a chart looked mild, but function and comorbid risk push you to escalate it early on?
Yeah, I have, especially when people come in and they don't tell you how long they've really had something, or they're not consistent with their medications. Those are always bad. Or they have other things like heart problems. Obesity also takes a toll on psoriasis, it makes it worse. So they'll come back and they're like really, really bad. And you're like, why is this surface area growing so much? And to be honest, it's also the point where it's hard. It's disheartening to have to think that you have to put on something every day, constantly, especially if it becomes a large body surface. But then they're terrified of biologics because at the end of those commercials, you see this is the side effect. So a lot of them are like, I'm not trying to do that, or even give themselves injections. So I've had places where I've had to go, okay, you can come into my office and I'll inject you.
Mm-hmm.
Even though they're supposed to go home and do it, it's fine. You can take that step and bring your patient back in, and it saved a lot of people. Then after a while, some get courage, some don't, and it's fine. See your patient, get them along.
Mm-hmm. How do you match biologic class to specific clinical scenarios such as nail dominant disease, concurrent PSA, metabolic syndrome, or a history of IBD?
You have to keep up on your literature, especially with the nail and palmar and scalp. IL-17 inhibitors are really great. Talus is great, especially they did a lot of the research, especially for nail pitting, palmar, and genital. And they're also great with scalp. They did a lot of specific sites in their studies. And I noticed that after they came out, other companies did the same. They also got a indication for children, which was great, 6 to 11. So did Stellara, and I love Stellara. Stellara is one of the original ones. The downfall of Taos for some people is that you have to do it more often, once a month, as opposed to Stellara, which is every 3 months. So lifestyle, because especially if you're a busy lifestyle, jet setting across the world, you're not trying to bring your biologic with you all the
Mm.
time.
What are your rules of thumb for when to optimize dose or interval versus declaring primary or secondary failure and switching to a different mechanism of action?
Well, that's the hard part. It used to be easier, but it's hard to change somebody from one to another because most insurance companies like, well, we're not going to go back. And you don't want to build up like antibodies to the actual treatment once you stop the treatment. And that is a risk that you take. I've had people who even said they just want to stop to see if it gets better and go, and then you try to go back and they go, it doesn't work anymore. So before I do that, I go, why don't we put a concomitant treatment like methotrexate? It helps with the flare, brings down the flare, and then it kicks back in that biologic so it helps again. Give it 12 or 14 weeks to make sure, even if it's not totally better, that it improved before you stop them. Because then after that, like I said, it's hard to go back. And I would change class. I wouldn't go from like Cosentyx to Talx because those are
Mm.
both the same. You change that entire class of the
Mm.
medication.
How often does antibody buildup happen and people get resistant to treatment? And are there populations or maybe times in life when that's more likely to happen? Let's say if you're treating, pediatric patient and then they go through something like puberty, are there milestones that make that more likely to happen?
That's a good question. And you're right, because they do grow and they change. So I also think about hormonal changes with women. It also takes a part of it, or people when they get comorbidities. But just being on something, your body itself becomes used to it and it won't respond the same way. I would think maybe 20-30%. It could be more, but that's what I've seen in my own practice, where that's why I'm a little bit more hesitant to change people. And I want to make sure it really has not worked before I change them.
Hmm. And speaking of hormones, how do things like pregnancy, lactation, pediatrics, like I mentioned, severe palmoplantar or genital psoriasis change your ladder? What would you like community dermatologists and other prescribers to do differently, in your opinion, in these groups?
So, especially for pregnant or lactating mothers, that one's a little bit more apprehensive because you don't want to go against a gynae. And you should talk to somebody who is pregnant with their obstetrician to say, let's work together. She's already been on a medication. There is one that actually is has an indication in pregnancy, and that's Cimzia. It's a tumor necrosis factor biologic. But you should really work with that obstetrician before you do that. Pediatric indication, definitely. Humira has always been out for like rheumatoid arthritis. So that was one of the older ones that you can use in children. But Stelara, like I said, Taos can do the same. You want to make sure that they don't have like bowel syndromes and stuff like that. So there are some that you would never give somebody who has like a concomitant, like irritable bowel syndrome, like Cosentyx, because that's one thing that might make it worse. So you do have to look at their comorbidities.
Hmm. What is your standard monitoring plan, like labs visit, infection vigilance for a stable patient on methotrexate or a biologic? And where do you think clinicians commonly over or under monitor?
So, I'm from the age where some biologics were taken off the market, and it is very disheartening to sit there and go, I just gave somebody this. So for biologics, in the beginning, I just give them every 6 months, especially the ones they take, and I want to monitor you. I need to see what's going on. And actually, more insurance companies are saying, when's the last time you've seen your patient that you want all of a sudden for us to refill this drug with? So every 6 months, I don't think it's overboard. In the beginning, I would do it more often. And I don't think I really needed that.
Mhm.
Um, for methotrexate, definitely I wouldn't go past two. It's 2 to 3 months, and usually it's two because that has carries more immediate side effects, and you want to make sure you don't miss an emetic cough or a drop in WBC. So you definitely want to see them a little bit more often. And that one isn't more long term to me for psoriasis, though I have some people who have stayed on it longer. It's not the usual long term drug.
When a patient is better but not clear on a biologic, what is your stepwise approach? Topical optimization, adherence work, combination systemic, dose adjustment, or class switch? And in what order?
So pretty much I always start with everybody with a topical, see how they respond. But I also see the body surface. You can respond, but is it going to be a great effective long term? Getting biologics covered are hard. Otezla used to be a good one, but is that side effect of possibility of depression or suicidal thought? And I'm not saying that everybody gets it, but as a clinician, especially in a community by yourself, you don't have that much backing. You're trying to do the least. So Tiku is a new one that came out, tyrosine kinase inhibitor. It's an excellent drug. It doesn't carry that side effects for people who are more inhibited to doing the injections. And there's some new topicals that are out, like Zovary came out, and it's an actual decent drug that helps to decrease psoriasis. But I still my go-to is Skyrizi. I actually like Skyrizi. It's every 3 months, so you don't have to do it as often, and has a really great clearance rate.
What practical strategies have you found effective for managing erythrodermic, pustular, or rapidly progressive psoriasis in the real world, including when to use cyclosporin or to even maybe hospitalize?
So I must admit, I had one erythroderma patient, and they're a little scary. You're like, oh, okay, what's going on? So the first thing you want to do is, especially if they have a lot of open areas, is pretty much give them, like I do wound repair. So there are wound repair creams that are out there like Biafin, um, Lexamend, Episerum. They're great creams. If it's too much of a body surface area, that's when you definitely go to the hospital. You're like, you have to go in. But there's some that you can manage, especially if it's not too widespread, and topical corticosteroids. But those management to get that body temperature under control, because you lose body temperature when you have no skin coverage on the epidermis. Pustular, definitely you want to put on some antibiotics with them and topicals to dry up. Like, people don't utilize like gel-like corticosteroids, but gel-like ones,
Mhm.
they dry up those pustules really well.
Interesting. Um, how do you handle patients with significant metabolic or cardiovascular risk when choosing and sequencing systemic biologic therapy?
Oh yeah, you want to go for the safer profile drugs
Mhm.
like I said, Stelara, Skyrizi. They're not bad. They're great. They don't really have that metabolic syndrome associated with it. Humira doesn't, and Taltz is pretty good as well. Tremfya is also a good one. So those avoid those side effects from coming up.
Mhm. Are there any, I mean, cases that you would consider, I don't want to use this word, but a nightmare case that kind of changed how you think about managing psoriasis now, that might have some gems in it for other practitioners?
Well, it was my Palmer plantar one. She started to get oral lesions, and you can get oral lesions in psoriasis. It started getting red and bloody, and I'm like, okay.
Mhm.
And of course, it's in the evening. She comes in. I go, okay. So at that point, I'm like, we need to call out. We need to make sure that if this gets worse, we need to go to an ER, or we need to go to an ambulance. And of course, she didn't want to. So it was out there for a while. We had to do oral treatments. I called my friends who were oral surgeons at this point. We're trying to stop bleeding. We're trying to calm it down. And there are lesions. There are medications like oral paste and that is a cortisone that calms it down. There are spit and swallows that are made up of different combinations of lidocaine, tetracaine, doxycycline, calm her down because she was nervous to go. She eventually ceded and said, I'll go to the hospital. But those kind of cases come up, and she was very febrile. I'm like, you're sick, you're bleeding out of your mouth, you can't walk, you're just kind of, she's like, but I don't want to leave. I want you to take care of me.
Mhm.
At that point, I said, well, we'll take care of each other. And I worked with a doctor, the hospitalist that was going in, but that was a nightmare. And in that case, it's kind of like it doesn't matter. You're not hurting your patient's feelings, not sending them to the hospital. You have to call an ambulance and they have to go in.
Wow. So to close out, if you had to give a dermatologist and other prescribers maybe two or three concrete changes to improve psoriasis diagnosis and treatment, maybe one at the exam level or the prescribing level, whatever sticks out to you, what would they be?
Don't judge a book by its cover. I hate to say, when in dermatology, skin presentation is everything, especially with pigmentation. Don't just automatically think that person has eczema. You have to really do an exam because you're going to lead to more scarring later. And don't be afraid to say you have psoriasis, or if you're not sure, do the biopsy. And pretty much also listen to your patients because your patients do have that history, and make sure that they don't things that exasperate it, drinking alcohol, certain medications. Look at their medications, like beta blockers, lithium, hormones, hormone replacements. And kids can get psoriasis too. History of strep throat, untreated especially, leads to psoriasis.
Wonderful. Well, this has been a great conversation, Dr. Honore. Thank you so much for joining us on MD Newsline.
Thank you for having me. This is always wonderful.